Hello, everyone, and good afternoon. I'm Stephanie Maselli. I'm a media officer with the National Academies of Sciences, Engineering, and Medicine. And thank you for joining us today for our webinar for the recently released report, Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare. To read the full report, you can visit nationalacademies.org/primary care. You can also find briefs, short summary of the report, and a host of other materials there too. And the slides and recording of this webinar will be available on that page as well in the next few days. For those of you who are not familiar with us, the U.S. National Academies of Sciences, Engineering, and Medicine are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the entire committee, and they must undergo external peer review before they are released, as did this report. We have here with us several members of the committee to discuss the report. We'll also have quick remarks from National Academy of Medicine President Dr. Victor Zhao, and then the committee members will give an overview of the report and we'll open it up for Q&A. Before I introduce the committee, though, just a few reminders. This webinar is scheduled to last 1 hour and 15 minutes. We'll start with a presentation summarizing the report by the committee members, and then we'll open it up to any questions you may have. You can simply click the Q&A button on the bottom of your screen to submit a question. And if you have any technical issues during this webinar, you can contact Zoom technical support at 1-888-799-9666 and select option 2. With that, let me introduce the members of the committee that wrote the report who are here with us today. We have Linda McCauley, our co-chair, who is Dean of Nursing at Emory University. We have Bob Phillips, also co-chair, who's founding executive director of the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine. We have Carrie Kola, professor at the Dartmouth Institute for Health Policy and Clinical Practice at the Geisel School of Medicine at Dartmouth College. We have Shauna Hudson, professor, the Department of Family Medicine and Community Health, and founding director of the Center for Advancing Research and Evaluation for Patient-Centered Care at Rutgers University. We have Chris Kohler, who's president of the Milbank Memorial Fund. And we have Alex Christ, who is professor of family medicine and population health at Virginia Commonwealth University and practicing clinician and teacher at Fairfax Family Practice Residency. And with that, I'd like to turn it over to our co-chairs. We do have a slight shift in schedule here. Rather than opening remarks from Dr. Zhao right at the beginning, we will include those at the end. So I'll hand it over to our committee co-chairs.
Thank you, Stephanie. As Stephanie said, I'm Linda McCauley, the Dean of Nursing at Emory University, and it's my pleasure to be with you this afternoon. And I'd like to begin by recognizing the phenomenal committee who have worked together in the last 18 months to make this afternoon happen. Next slide, please. So this was a very large committee of 18 selected members, staff, and fellows from the National Academy of Medicine also. And this work could not have been possible without this wide array of expertise. And so you can see their names there, but let me tell you a little bit about how we came together. The expertise that were on the committee, first of all, a nice representation of clinicians that included physicians from family medicine, internal medicine, pediatrics. Nurses were on the committee, dental health representatives, pharmacy representatives, physician assistant representatives. So you will see that this led to a strong emphasis on interprofessional teams working together. We had a great representative from a community health worker program, which really focused the patient or the individual focused, patient-focused work in the report. We had a CEO of a health center delivering primary care every day. We had state and federal health policy experts, economists, anthropologists, and sociologists, which I think all of this expertise has led into a phenomenal report that we have in front of us today. Next slide. And equally impressive are the study sponsors. You can tell by the number of sponsors on this report, the wide arching interest in this topic, primarily to look at the state of primary care in the United States today and where we need to go. So this work could not have been possible without these important study sponsors. Next slide. So our statement of task was simple but complex. We were charged to examine the current state of primary care in the United States and develop an implementation plan. And this was a new challenge for this committee. Many times you're on committees where you make recommendations, but we were asked to focus on how to effectively develop an implementation plan that would build on the recommendations of the previous 1996 IOM report on primary care, America's Health in a New Era. We were asked to look at ways to strengthen primary care services in the United States, and especially for underserved populations, and to inform primary care systems around the world. Next slide. So over the last 18 months, we had 5 meetings. One was in person. The rest of our meetings were virtual. We had a webinar and we had many conference calls. We had 3 public information gathering sessions where we listened to our sponsors. We listened to the public. And we also had 3 commissioned papers to assist the committee in its analysis of this problem. And these papers focused on the historical evolution of primary care, the effects of the pandemic that was upon us as we did this work, and payment reform. We did an intensive literature review, more than 6,000 articles, and synthesized those findings and conclusions. And as Stephanie said in the introduction, all of our recommendations were driven by consensus of all the committee members. And then finally, and a very important piece is we want to thank the 16 experts from a variety of disciplines who provided the external peer review for this report. Next slide. So I want to turn it over to my co-chair, Bob Phillips, who will give you the context of the study.
Linda, thank you so much. This is Bob Phillips at the Center for Professionalism and Value in Healthcare. And study context really focused on the fact that primary care is the only part of the healthcare system that on a population level produces longer lives and more equity. The pandemic made that the long-standing health inequity in the United States more visible, and likewise it showed just how important primary care is in the United States and how neglecting it made it more difficult to respond to the pandemic. For those who don't know, primary care provides comprehensive, person-centered health care for individuals, families, and communities. In countries with high-quality primary care, they experience better health outcomes and greater health equity than we do in the United States. And in the United States, primary care is financially under-resourced and lacks a unified voice within the Department of Health and Human Services. Primary care is inaccessible for large portions of the population, and visits to primary care are in decline and the workforce is shrinking. We have primary care workforce shortages that can be linked directly to reduced life expectancy. Next slide, please. This figure looks at three sectors of the healthcare system: primary care, specialty care, and hospital care. It derives from some of our best national surveys of the population and their experiences in health, showing that primary care and specialty care provide about a third of all healthcare visits each, but primary care only gets about 5% of total healthcare spend compared to specialty care and hospitals. Those expenditures are lower than most of our comparison peer countries, other developed countries around the world. Next slide, please. This underinvestment leads to health inequity, financial pressures on practices, clinician burnout, suboptimal care, including erosion of life expectancy gains over the last 100 years. As I mentioned, other developed countries have higher expenditures on primary care. And what the pandemic really revealed is that primary care has no federal champion, no agency within HHS that has an overview of primary care. It was not part of our national epidemic plans before the pandemic. It was not specifically mentioned or supported in congressional relief bills. It really only became part of the vaccination distribution plan in the last few weeks, despite being the largest platform for vaccination and the place where most people turn for trusted health relationships. And like many small businesses, primary care saw reductions in visits and therefore payments, and we're still trying to assess what damage is done to the infrastructure for primary care. Telehealth regulation relaxation was a really good thing, and we're still waiting to see if that will stick around. Next slide, please. So the 1996 Institute of Medicine report on primary care was actually preceded in 1994 by a definition, and that definition helped galvanize that committee in working on the 96 report. So our committee naturally revisited that definition and modified it some to reflect key societal and sector shifts since 96. Some of those shifts include the provision of services to integrated whole person health, how foundational primary care is and the value of sustained relationships at the core of that, the importance of communities as a focus of high quality primary care, and the need for primary care to be equitable. It has a greater focus on interprofessional teams in delivering primary care and acknowledges that primary care is delivered across a variety of settings and modalities. Next slide, please. The committee strongly believes that because of its societal value and role in health equity, that primary care should be a common good, accessible to everyone. And the goal of the implementation plan that you'll see in a few minutes is really to elevate primary care to this common good status. We understand and respect the fact that patient choice is important, but we're not going to compete our way to a stronger role for primary care in our delivery system any more than we can compete our way to a stronger elementary or secondary education system. We really need strong advocacy on this point about primary care as a common good. Now I'm going to turn the next set of the presentation slides over to my good friend, Chris Kohler.
Thank you, Bob. As Linda pointed out, the charge for our group is considerably different from, or to the committee is considerably different from 1996. We're charged with an implementation plan. That is, we go into this report knowing the value of primary care, as Bob has stated, and we actually know how to do high value primary care in small instances. The challenge that the committee was given was to think systematically about how do you implement it? How do you scale these examples of high value primary care? For that, the committee needs an implementation plan, and the implementation plan consists of the three components that you see here. First is a comprehensive view of healthcare as a system, a system with components at the macro level, that is state or federal policy setting, at the meso level, which is larger organizations that have systems of care, and then at the micro level, the everyday encounters between patients and their primary care teams. And an implementation plan has to take into account these three elements of a system. The second part of the committee's implementation plan is the concept of accountability, both for public and private actors. As you will see, accountability is particularly important in the case of a common good for public sector actors to hold them accountable for advancing the actions that we recommend. And its current, this accountability mechanism is currently lacking. It's one of the important components of our recommended actions. And the final component of the implementation plan is this concept drawn from public policy thinking of a policy window. We believe that there is a policy window to implement high quality primary care and to institute this notion of primary care as a common good. We see a public that is concerned about their future access to healthcare and the stability of the healthcare system. Bob has already pointed out that primary care is foundational and fragile. COVID has shown the poor system response and the economic and political power of certain elements of the healthcare system. There is a role for primary care in a system of care for pandemic response. We're seeing that even in recent weeks as we deal with the crucial role of the relationships developed in primary care to address vaccine hesitancy. Addressing that is critical to our full economic recovery. Finally, the third element of the policy window is that we are having a national conversation right now about justice and about the role of government. And as Bob has noted, primary care is the only part of the healthcare system that can actually reduce healthcare disparities at a population level. Next slide, please. So the committee's actions, its implementation plan, can be grouped under these 5 objectives that are listed here. 4 foundational elements for payment, access, workforce, and digital health, tied together by the notion of accountability. And the committee is recommending 16 actions grouped under these 5 particular objectives. We'll go into more detail on these objectives on the next slide, please. The specific phrasing of these objectives is important. They capture both the goal of high quality primary care and the actions underneath each that we believe are necessary to implement high quality primary care. First, it's important to pay for primary care teams to care for people, not individual doctors to deliver individual services. We believe the nation gets what it pays for, and payment reform that supports and encourages high quality primary care rather than actively discouraging it is fundamental to our vision of high quality primary care. This means paying for teams, not for doctors, and it means paying for people, not individual services. We believe the government has a fundamental role in leading this transformation by virtue of its status as the largest and second largest payer in the Medicare and Medicaid programs. Our second objective is to ensure that high quality primary care is available to every individual and every family in every community. Everyone in the country should have easy access to high quality primary care that is person-centered, relationship-oriented, and responsive to the needs of the community. This need for access is not only a matter of justice to achieve improved health and health equity, but it's also essential to implementing high quality primary care to build the broad political support for the concept of a usual source of care that everyone is entitled to and everyone declares. This concept implies a 3-way relationship or partnership between patients, their clinician teams, their primary care teams, and their payers. It's backed up by government as a nation's largest payer and the government's obligation to protect vulnerable populations. The third objective is to train primary care teams where people live and work. When primary care training is interprofessional and located in community settings, it's more effective at developing the skills that will keep people connected and healthy. It's worth noting, as the committee does, that this training is directly counter to what we do now, where we train individual clinicians in inpatient settings. Again, These policies are driven by federal policies and federal reimbursement. The fourth objective is to design information technology that serves the patient, the family, and the interprofessional care team. New health information technology standards should prioritize and facilitate integrated care that is consistent with our definition, person-centered, it supports relationships, and it's responsive to the needs of the community. We find too often that health information is used for competitive advantage to the detriment of those relationships. Finally, we need to ensure that high-quality primary care is implemented in the United States. This requires clear and meaningful measures of whole person care. It requires ongoing research, and it requires leadership in the federal government to assure federal policies that will support its development. As a common good, primary care is a federal responsibility. As Bob noted, we will not compete our way to the objectives of payment, of access, of workforce, and of health information technology. We propose in our report specific accountability mechanisms to get the work of implementation, measurement, and research done. The remainder of our discussion today will focus on the specific actions underneath each of these 5 areas. First, I'm pleased to welcome my colleague, Carrie Kalla, who will go through the payment actions. Thank you.
Thanks, Chris. And thank you to all of you for your engagement in this important work. I'm happy to share the committee's recommendations on primary care payment with you. Again, I'm Carrie Kalla, professor at the Dartmouth Institute for Health Policy and Clinical Practice at Dartmouth College. Next slide. Action 1.1, payers should evaluate and disseminate payment models based on their ability to promote the delivery of high quality primary care, not only short-term cost savings. So we've seen a focus on evaluating payment models, broadly speaking, on short-term savings. And so I think we want to incorporate other types of metrics into dissemination of payment models, such as support for patient experience, support for different types of providers across different communities and geographies. And another example would be stability under a pandemic such as coronavirus. The committee broadly recommends a multi-payer shift away from fee-for-service as the default payment model. We recommend the use of hybrid models, which are part fee-for-service and part capitation with fixed monthly fees, where fee-for-service is used in the case of services we want to encourage as clinicians gain experience with the model. The payment model needs to be consistent across payers, both to motivate change and to simplify the reimbursement environment. This primary care payment model should have 4 characteristics. First, it should support interprofessional, integrated, team-based care. Second, it should be risk-adjusted for both medical and social complexity of the patients. Third, it should allow for investment in practice transformation and infrastructure. And fourth, it should align incentives to measure and improve outcomes. Of note, the committee also recommends that for larger providers already engaged in population-based risk-bearing contracts between a delivery system and a payer, such as accountable care organizations, payers engaged in these contracts should ensure that sufficient resources and incentives in those systems flow down to primary care. Next slide, please. Despite recommending this move away from fee-for-service, the Medicare physician fee schedule retains an important role in our payment system as it is used by many payers and is often the basis for capitated payments. Currently, the American Medical Association's Multi-Specialty Relative Value Scale Update Committee, colloquially known as the RUC, plays an influential role in describing the resources required to provide various physician services. We recommend that CMS should increase the overall portion of healthcare spending for primary care by improving the Medicare fee schedule and restoring the RUC to its advisory nature. Broadly, we recommend that CMS create and invest in independent data collection and valuation tools to identify overpriced services while maintaining budget neutrality. Fourth, the support of states is pivotal in implementing the changes recommended by the committee. States should facilitate multi-payer collaboration and increase the portion of healthcare spending for primary care. So states should use their authority to facilitate multi-payer collaboration and further should measure and support an increasing portion of healthcare spending to primary care. Several states are taking leadership in this area by either passing legislation or by issuing executive orders. Examples include Rhode Island, Delaware, Utah, Colorado, Oregon, Connecticut, Washington, and Vermont. Next slide, please. In summary, the committee recommends a complete phase out of pure fee-for-service in primary care, shifting the default to hybrid payment models with patient assignment to primary care teams and adequate resources for transformation. We expect the combination of some downside risk, a reevaluation of evaluation and management services, and health system accountability to translate to sufficient resources to implement high-quality primary care. Next, I'm going to hand off to Dr. Shauna Hudson to discuss access.
Thank you, Carrie. Good afternoon. I'm Shauna Hudson, and I'm a professor of family medicine and community health at Rutgers University. And I'm going to be presenting the committee's second recommendation, which is focused on access and ensuring that high quality primary care is available to every individual and every family in every community. Primary care is foundational to our healthcare system and critical to achieving health equity. Chapter 4 of our report reviews significant literature on the impact of person-centered, family-centered, and community-oriented primary care. It also importantly described what the committee heard from patients and advocates and community members about what primary care means to them and how it can better serve them. And through our review, the committee came away with a shared understanding that when more people have access to primary care, we have healthier populations and more equitable outcomes. The committee took from these inputs a need to reform how we think about implementing high quality primary care and focusing on individuals and families in the context of their communities to provide what we call whole person care. For this reason, as Bob and as well Chris mentioned before, the committee recommended that primary care be considered a common good available to all in the United States, regardless of insurance status. It should be promoted with responsible public policies, private sector action, and also be sufficiently resourced to drive health equity. Next slide. To these ends, the committee has proposed 5 different action steps under the second aim. The first one proposes what we call universal empanelment. All individuals should have the opportunity to have a usual source of primary care and have an ongoing relationship with that primary care. For payers such as Medicare, Medicaid, commercial insurers, as well as self-insured employers, this means that they should ask on an annual basis all covered individuals to declare a usual source of primary care. They should assign non-responding enrollees using established methods to track this information and use it for payment and accountability measures. For the uninsured, in the settings where they seek care, such as our healthcare centers, our hospitals, and our primary care practices, those settings should assume and document ongoing clinical relationships with the people that they are treating. Our second action focuses around support for the underserved. And here, our report recommends that HHS, enabled by congressional appropriations, target sustained investment in the creation of new health centers in federally designated shortage areas. This would include increasing federally qualified healthcare centers, lookalikes, school-based clinics, rural health clinics, and as well Indian Health Service facilities. Next slide. Our third action proposes that we improve access, and this focuses on Medicaid beneficiaries and recommends that CMS revise and enforce its fee-for-service and managed care access standards for primary care, ensuring adequate access. Also, we expect that they would provide technical assistance resources to state Medicaid agencies for implementing and attaining these standards, as well as measure and publish how states are performing. Our fourth action supports equity by permanently supporting the COVID era rule revisions and Medicare and Medicaid benefits interpretations that have facilitated integrated team-based care. These revisions have enabled more equitable access for telephone as well as virtual visits. They've provided equitable payment for not in-person visits. They've eased documentation requirements, expanded the role of interprofessional care teams. And in our fifth action, we propose that there should be community co-creation and partnership building. Primary care practices should move toward a community-oriented model of primary care by including community members who have lived experiences in their governance in their practice design and as well in their practice delivery. They should be partnering with community-based organizations. And importantly, our accrediting bodies should also be encouraging this by revising our standards to facilitate these changes. And I'm now going to hand back to my colleague, Linda McCauley, for the next season.
Thank you, Shauna. So critical to improving access and critical to changing our payment system is having a sufficient workforce that understands the communities in which they serve. And so our third major area is to shift our current way of preparing the primary care workforce to train these teams where people live and work. Next slide. So we only have two actions in this area, but they are critically important because our primary care healthcare system will not stand up and be successful without a sufficient and adequate workforce underlying the work that's to be done. And so healthcare organizations need to continue to strive to diversify the primary care workforce and to customize teams to meet the need of the populations they serve. Primary care teams will look different in different places, and they will reflect the communities in which they are serving. Government agencies have also got to look at the educational pipeline models and evaluate the incentives and disincentives for individuals to go into primary care. And clearly, there's a need to improve the economic incentives for young practitioners to go into being a primary care servant. There are a number of actions that the government is already employing that we recommend be expanded. For instance, workforce training initiatives from CMS, the Department of Veteran Affairs, HRSA, different states, all of these types of programs that redeploy or augment Title VII, Title VIII, GME funding are absolutely critical to having this primary care workforce. But changes need to be made so that there are incentives to support interprofessional training and that the training take place in community-based primary care practice environments instead of large healthcare systems where most of primary care does not take place. So I'm going to turn it over to Alex Christ now to talk about technology.
Thank you, Linda. And once again, I'm Alex Christ. I'm a family physician at Virginia Commonwealth University. Digital health was not in the 1996 report, so this is new content. It was added because digital health is an essential component of our healthcare delivery system today, and its role will only continue to grow. Without high-functioning digital technologies, none of the aspirations of this report are possible. Digital health has become uniquely important for primary care because primary care is comprehensive. Clinicians need to focus on whole person health. This means they need whole person information applied to any potential situation. Primary care is a point of first contact. This includes the first point of information seeking for new health issues. Primary care is charged with coordinating all of healthcare, and we've relied on primary care to find, enter, and share comprehensive patient information. This is a monumental task, and it's unfair to ask of primary care. When the committee considered digital health, it broadly considered any use of health information technology to care for individuals and communities. Tools include electronic health records, patient portals, mobile applications, telemedicine platforms, and the list goes on. With this background, the committee had two overarching recommendations for digital health. So first, ONC and CMS should develop the next phase of digital health certification standards that support relationship-based, continuous, and person-centered care, simplify the user experience, ensure equitable access, and hold vendors accountable. This is fundamentally different from our past 3 phases of meaningful use, which, while useful for promoting the adoption and implementation of EHRs, fell short on supporting what primary care needs today. We're asking for systems to align with the functions of primary care, support relationships, provide access and continuous contact over time, collect the patient's story, and have a person, patient, family-centric focus rather than the current disease focus. To demonstrate that digital health is doing what we need, systems need to automatically measure user experience. Clicks and time spent using the system, data transferred without manual review, improved efficiency of care, and ultimately improved health outcomes. Primary care needs sense-making functionality to make the right care at the right time easy to deliver. In this time, we need vendors and state and national support agencies, not clinicians and health systems, to be held accountable and financially responsible for failing to deliver on benchmarks. Second, we're recommending that ONC and CMS plan for and adopt a comprehensive aggregate patient data system to enable primary care clinicians and interprofessional care teams to easily access comprehensive patient data needed to provide whole person care. This is a big ask, but we can't continue to silo information. This leads to inefficiencies, it leads to waste, and it leads to errors. Comprehensive data needs to be usable by any certified digital health tool, and this can be accomplished by 3 mechanisms. There can be a centralized comprehensive data warehouse. Second mechanism could be individual health data cards, or third, a distributed sources connected by a real-time functional health information exchange. Each approach has unique challenges, but fundamentally, any healthcare provider should be able to instantly access all of a person's health information with permission at the point of care to give them the information they need to help the patient. Bob, I'll turn things back to you now.
Thank you, Alex. I'm going to cover the 5th objective, which, as Chris Kohler said, kind of wraps around the other 4 to ensure that there is a process for implementation and for accountability. Next slide, please. The first action under this objective is that the Secretary of Health and Human Services should establish a Secretary's Council on Primary Care. And as I noted at the very beginning, this is because there really is no federal champion for primary care that has a view of primary care and considering policies or how to respond to a pandemic. We think the council members should include the CMS administrator, the directors of the Centers for Medicare and Medicaid Innovation, HRSA, the Agency for Healthcare Research and Quality, the Assistant Secretary for Planning and Evaluation, and the National Coordinator for ONC. That council should really coordinate primary care policy across all of HHS with attention to the following things. The first is to assess federal primary care payment sufficiency and the policy needed to deliver it. The ability to monitor primary care workforce sufficiency, including training, financing, production and preparation, incentives for locating in federally designated shortage areas, and for staffing federal clinical assets or investments like health centers and rural health clinics, Indian Health Service, and the VA. To coordinate and assess the adequacy of the federal government's research investment in primary care. The 4th is to address primary care's technology, data, and evidence needs that Alex so articulately covered. To promote alignment of public and private payer policies in support of high quality primary care. And lastly, number 6, to establish meaningful metrics for assessing the quality of primary care that embraces person-centeredness and the health equity goals our country is struggling to set. As part of its coordination role, the Secretary's Council should verify that there's adequate budgetary resources and that they're allotted in respective agencies for fulfilling these responsibilities. It should annually report to Congress and the public on the progress of its implementation plan and the performance on each of those 6 responsibilities. And in all of its work, the Secretary's Council on Primary Care should be informed through regular guidance and recommendations provided by a Primary Care Advisory Committee created by the Secretary under the Federal Advisory Committee Act. So both of these things have existing authority for their creation. Next slide. Action Action 5.2 acknowledges that a decade ago, the National Institutes of Health formed a Center for Emergency Care Research that was instigated by a series of Institute of Medicine reports like this one today. We feel that the committee recommends that the Secretary form an Office of Primary Care Research on the NIH campus, and that Congress which specifically gave the Agency for Healthcare Research and Quality a charge for supporting primary care research, but never funded it. So the committee is calling for prioritized funding of primary care research at AHRQ, in addition to this NIH Office of Primary Care Research. Action 5.3 acknowledges that successful implementation will need a scorecard and a referee. The report, Appendix E, offers a high-quality primary care implementation scorecard that Chris Kohler will cover in more detail. And we propose that primary care professional societies and consumer groups should be those referees, using the scorecard to publicize success on the 5 key implementation objectives identified in this report. And we suggest that 1 or more philanthropies assist in convening and facilitating the scorecard development and compilation. Chris, over to you.
Thank you, Bob. Just a little bit more detail on the scorecard that the committee is recommending. Quality improvement experts tell us that we cannot improve what we don't measure. And the committee maintains that just as we focus on statistics such as unemployment, economic growth, life expectancy, we need to focus on the health of primary care as the foundation for our healthcare system. Therefore, the committee took it upon itself to recommend a scorecard using these criteria that are listed here for recommended measures, that they're already in use, that is not new, which poses quite a challenge, that they're few in number, easily understood and consistent, that they're built on reliable data that's regularly collected and publicly available, and then we can use them at the national and at the state levels. So you can assess the health of primary care both at the national and at the state level. There are other units of accountability, communities, health systems. We don't have access to national measures that are collected on a reliable basis. So we're proposing the feds and the state as units of accountability. We've recommended those measures organized by the objectives that we've discussed here. It's worth noting that because of the criteria that we established, particularly that they're already in use, there are some objectives that are underrepresented, notably health information technology. But if we want to measure the health of primary care, it's important that we use the tools that we have at our disposal now. There will also be efforts to develop new measures. But it's important to hold the federal government and the state governments accountable using the measures that we have. So Appendix E in the report contains that recommended scorecard. And as Bob notes, there is a recommended implementation process with philanthropies assembling the measures and various stakeholders, including providers, consumers, employers, and health plans, using it to raise the visibility around the health of primary care and the ability to implement or the current status of the implementation of the actions that the committee has recommended. That completes the discussion of the recommended actions in the committee's report. I'm now pleased to hand it back to Bob and Linda, who will lead our question, answer, and discussion session. Thank you.
So thank you. Do we have any questions for the committee to entertain?
Yes, and thank you all. Before we do that, I did want to invite Dr. Victor Zhao, who's the president of the National Academy of Medicine, to give a few remarks. Just as a reminder to attendees, please keep on clicking that chat button, that Q&A box to submit your questions. We want to hear from as many of you as possible. Thanks all. I think you're on mute, Dr. Zhao.
I was saying thank you, Stephanie, and let me thank profusely the committee led by Bob Phillips and Linda McCauley. This is an outstanding report. I listened to all of it, I read it, and I would say the take-home messages are high quality primary care is the foundation of high functioning health system. And it's critical for achieving the quadruple aim. I think the other really important message, of course, is that it's a common good. And I totally buy it. This message is so powerful because if we look at where we are today in our country, look at issues of quality, access, equity, and particularly during COVID, it's very, very clear that we're missing primary care as the pillar for all our activities. Now, as pointed out by Linda and Bob, the 1996, the IOM did have a great report and made many recommendations. Question we need to ask is what happened to it? But I do think we have renewed energy today. That is, we really are committed to say, let's have some action. So I love your implementation plan, the systems view, the accountability, and the policy window. Let me reflect on some of them. First of all, I think there's no question that we need primary care to be available to every individual, every family, in every community. And that people who practice primary care need to be trained where they live, where people work and live, particularly interprofessional training. And that's really important to have connected care with the right IT system and the use of digital care. Now the question is, what do we need to make it happen? The committee says payment reform, and I couldn't agree more. If we don't fix the payment system, and if the feds don't take this on as a fundamental responsibility, we'll be still where we are today. Second is the process for implementation. I thought that the steps going forward are so clear. So I think we all want to achieve patient-centered, relation-focused, access team-based care that's equitable. How do we do this? Now, Bob said feds and state are units of accountability. Also Chris, and I totally agree. Now, so our work actually just begun. This great report that puts forward in detail the different accountable parts of our organization or country to implement this, we as a academy and as a unit together needs to be sure that these recommendations reach the policymakers. And one of the things we committed doing clearly is dissemination of this report, having engagement discussion, and making sure that is in fact right in the top of the agenda for the new Secretary of HHS. And I'm committed to doing this with you. Thank you.
Thank you so much, Dr. Zhao. We have a number of questions from attendees. So the first one is, could you elaborate on the committee's definition for primary care being a common good? And what are the implications of such a definition for resource allocation and utilization?
So Bob, you or Chris want to handle that one in terms of what we meant by being a common good?
Sure, thanks, Linda. I'll be brief, and Chris, please weigh in. It means that we have to really focus on making sure that the number of folks who have a usual source of care includes everyone, that capacity is there for anyone who wants one can have one. We have about 1,000 whole county health professional shortage areas that have not budged for more than 20 years. That is just one example of the geographic inequity we have in access to primary care. We have other barriers at the local level that need to be addressed, and that's what the report was really focused on.
And this is Chris Kohler with the Milbank Fund. The economist definition of a primary care is one that the economist definition of a common good is one that is rivalrous, meaning more for you is less for me, and where supply in the case of primary care happens, that's certainly the case, and non-excludable, meaning that we can't or don't want to exclude people from access to it. The committee feels that by virtue of the unique ability of primary care to improve the health of populations, literally extend life expectancy, and at a population level, not just for individuals, but for whole populations, and to reduce health disparities, that means that primary care poses a unique claim on society. The job of protecting common goods ends up being that of the government. So I would go back to something that Bob said. Fundamentally, what the committee is saying is that we will not exclusively compete our way to implementing high quality primary care for everybody. There is, just in the same way with education, in the same way with roads and bridges, there's a public responsibility to implement high quality primary care. Patient choice is important. If a particular team is not providing what is in the patient and family's notion of high quality primary care, they have to have the ability to have a choice, to vote with their feet. But fundamentally, the job of stewarding common goods rests with the government. And that's why a number of key recommended actions, refer to actions that the government should take.
Thank you.
Thank you, Chris. And you know, I think we need to be more aware, and the public needs to be more aware of the number of people in our country who do not have access to care, who, if they are ill, do not have that go-to place or person to help them through an acute episode. And I think it is critical to the access charge of the committee to recognize that everyone has that right to access. Everyone has the right to travel on our highways. Everyone should have the right to be able to find a health provider. And today they can't.
Our next question is, more primary care practices are being absorbed by hospitals and hospital systems. So how can we create strong levers to ensure the principles of this report are applied in these environments?
Well, that's a really good question. We see our healthcare systems as colleagues with primary care, but they are not in themselves primary care. And so how do we develop programs where the role of primary care within healthcare systems is clearly identifiable? That healthcare systems have a commitment to population health, and it begins with primary care. Others on the committee that want to add to that very important question?
Linda, Carrie's presentation of Action 1.2, it was very explicitly about this. So Carrie, do you want to unpack that a little more?
Yeah, we addressed this specifically in Chapter 9 with the recognition that many of the contracts we're talking about are between a very large provider organization and a payer, and that doesn't always impact the way primary care is paid or resourced within the organization. And so our recommendation really puts the onus on payers to think about how the resources they're providing to the organization are being spread throughout, and what types of investments are being made in infrastructure. But Chapter 9 has more detail. Thanks.
One of the things that I think is also important is, and I know there are colleagues on this call who've worked on and very engaged in clinician burnout. And right now, the drivers for primary care, when primary care is embedded in a healthcare system, are completely wrong. And we find that primary care clinicians within healthcare systems are some of our most burnt out providers in the system. And it's very complex, but it is tied, like Carrie said, to the way that we pay for services in healthcare systems. And so all of this has to be realigned so that primary care providers have have the environments in which they can thrive and feel very satisfied in caring for patients, families, and communities. Another question, Stephanie?
I'm seeing a number of overlapping questions, so I'm going to try to combine them. In short, how did this report consider primary care integration with notably public health, with oral health, and behavioral mental health, for just a few examples?
So I think if you look at the difference in the 96 report and today's report, there is such an important focus on team-based care. And we were very inclusive on what the team is, and that communities should help define the teams that they need. I saw a question about what about social workers? Some primary care teams, it's an absolutely critical part. In another setting, dental health integrated with primary care is critically important. There is not one model that fits every community, but what is important is that every community is listened to for the services they don't have and what they need. Others want to pipe in on that one?
Linda, I wanted to just add to that because I think that there are two places in the report that people can sort of see the ways in which we were thinking about the integration of the different team members. And so the first one is really the chapter 4 that focuses in on individuals and communities and families. The second area is really the workforce chapter, where we go in and do a really nice deep dive about community health workers and other parts of the team that really weren't in focus back in 1996 that are really pivotal and important at this moment in terms of care delivery.
You know, I also want to say one of the reviewers of the report also pointed out to us team-based care is an excellent model. That does not negate solo practices that fit in well with the community and meet a distinct need. There's no, we did not prescribe the essential components for how to put these teams together. You only know that by listening to the communities that you're trying to serve.
And Linda, adding to that, there were some comments around relationships. So team-based care also doesn't negate the relationship. And that's something throughout the report that's front and center, the importance of that relationship. And that's what makes primary care the common good and so useful to individual and communities' health.
And I would just add that we built on another report from the Institute of Medicine, the 2012 report on integrating public health and primary care. Which also largely had little effect. And so we talk about that a lot in the report. And we specifically focus on the need for primary care to be able to reach into community, not just deal with the patient in front of them, but to address problems in community, which goes all the way back to the 1983 IOM report on community-oriented primary care. So, you know, we're not just reflecting and building on the 96 report. There have been a series of reports on primary care which have largely had little impact. And we're hoping that this one, in bringing those together, can help those relationships shape up in policy.
Thank you. We keep going back to the 1996 reports. There are a few questions. Why do you think those recommendations failed to gain traction or weren't implemented? And what's different this time around?
Well, I'll talk a little, this is Bob, I'll talk a little bit about why they might not have gotten traction and let my colleagues talk about what's different this time around. The 96 report was really conceived when the country was looking at healthcare reform. The Clinton healthcare plan, the Republican response to that, there were more than 20 proposals at the time. So there was a great deal of enthusiasm that this report might land at a time when health reform was richly underway, and that just didn't happen. The second thing is that health maintenance organizations and capitation for primary care was happening. There was a great fanfare for primary care that I know that affected me and my classmates and our decisions to go into primary care. And that also largely failed, except in some very key bright spots in the country. So at least two of what were very rich opportunities for primary care to thrive kind of dissipated at the very moment the recommendations landed.
The political context is always important, isn't it, Bob?
Well, Bob, I'll add too. I think some of what the committee was promoting with the Secretary's Council on Primary Care is we're trying to designate a group that is nationally overlooking and ensuring and charged with making sure that this is implemented, that primary care becomes the common good that we say it should be, and that these different steps and the group called on to carry out these steps are held accountable. And there's also some measures on a national level that we can look at to make sure that elements are being held accountable. So if that step is implemented, that goes a long way to trying to ensure that this moves forward.
And this is Chris Kohler. I'll comment on what's different about 2021 compared to 1996. In the last year, we've gone through a pandemic and struggled with that. We have realized the depth and the costs of the inequities that are existing in our social system. And we have watched life expectancy actually decline, even pre-pandemic. None of those were present in 1996. Primary care, we would offer, can help address all of those items. Ultimately, this is about harnessing the political will for changes that are supported by the evidence that we've put forth here. So this will transfer from presenting evidence to organizing for policy, which is hopefully this report informs, but the responsibility for using the report rests with all of us who care about the future of primary care and issues of population health and health equity.
The next question for you all is, what role do you think the overall healthcare payment system, for example, having both private and public payers, plays in the status of primary care? And would things improve or get worse if a single payer system were implemented?
Chris, you want to take that one on, or you or Carrie?
Carrie, they've heard from me. You start, and I'll chime in.
Well, I think the main answer is we don't know what would happen, but I would say that the committee considered the report in the context of today's healthcare system. So we didn't consider a single payer healthcare system. We tried to think about, in the context of where we are today in a multi-payer healthcare system, how could we get to more multi-payer collaboration in order to move primary care payment writ large and to be more coordinated across the spectrum.
And thank you, Carrie. And I would add that in the current multi-payer environment, I say this as a former health insurance executive and as a regulator, Medicare sets the tone. It's why the payment chapter focuses primarily on Medicare. As Medicare goes, so goes the commercial sector. If we can get Medicare valuing primary care appropriately, the commercial sector will follow.
But I think one of the challenges that we have in front of us is recognizing, as Chris said, the inequities in access, but also public perception around the value of primary care. And we can see even today that with vaccines, that the public is have very disparate views. And we would be naive to think in the implementation of this plan, that the public would be all on board and that this is a common good. It's very difficult for many people to understand the investment in primary care pays off in the future in so many cases. And so there is a huge piece of this that involves working with the communities. But just as we've seen with COVID-19, you have to get down on the streets of the community and work with people where they are and help them understand the value of primary care.
We have, going back to the primary care shortage, there's a question that says making training happen in communities is a laudable goal, but also getting the team to look like the community it serves is challenging. Aside from payment reform and graduate medical education inducements, what else is likely to attract more U.S. graduates into primary care, and specifically more Black and Brown applicants successfully going through medical school and into primary care careers?
That's such an important question, and it's something that all of our health professional schools and professional organizations need to be on board with. I actually believe a lot of our trainees, students come to us with lofty goals of executing primary care as we've described it in this report. But as they go through their educational and training programs, the incentives to stay in primary care are not there. And they have huge financial debt when they complete their programs. And they need to see these pathways to serving in underserved communities as a way to pay down the debt of their education. And there's some great models for this. There's just not enough of it for all the people that we need going into primary care. And so we need a national campaign for people who do want to serve the disadvantaged communities and make sure everyone has access. Shauna, you have anything to say about that?
I'm nodding, Linda, because you sort of nailed it right there in terms of incentives and wanting to go in and being able to come out of medical school with a pathway that makes sense. And so yeah, I think that it's really important, and part of the implementation challenge that I think we have here in terms of the workforce piece is really around how do we make sure that those incentives align in ways that primary care is seen as both viable as well as a desirable place to continue to do the work.
You know, a lot of people are advancing models of educating primary care providers to separate them out from the education of other providers in the healthcare system. And the committee didn't really talk too much about that, because we talked instead about how critically important it is for primary care providers to work with specialists and to understand how this back and forth, knowing their patients, their patient needs, recognizing the unique roles that specialists play beside primary care, that if you broke primary care away as an area where you train students in a silo, they would miss a major part of how the entire system works together.
The other thing I also wanted to just add is that, you know, we spend a lot of time talking about our clinician physicians, but the other piece here that there are other members of that primary care team. And so if we're thinking about nurses, if we're thinking about social workers, community health workers, the MAs, people who are working with the community, and then also bridging to the community-based organizations, there are a number of other opportunities that are in addition to medical school pathways that allow us to really provide, I think, a more robust sort of setting around primary primary care. So I want to make sure that we bring in sort of the team-based piece of this again, so that we make sure that that gets highlighted.
I recognize we're coming up on time, so we likely have time for 2 more questions. One of them is, how do you propose addressing primary care shortages in rural areas, particularly those regions experiencing hospital closures?
Well, Stephanie, I thank you for that question. Part of it is on how we prime the pipeline. So we know that bringing rural-born people into the health professions training pipeline means you're more likely to have rural workforce on the other end. That's really important. The committee looked at a lot of evidence that also shows that training people in those rural settings, rural health clinics, critical access hospitals, means you're much more likely to wind up in one of those settings again. The loss of some infrastructure, like some of those rural hospitals, is a real problem, because they're often kind of a base around which you can build a health infrastructure in a rural community. And so protecting those, while it wasn't a focus of the committee, has been widely endorsed by the National Rural Health Association and others. So I think all of those are going to be critical, and we talk very much about the priming of the pipeline and about training in those settings.
This might be hard to answer precisely, but I think it ties in well with the theme of primary care just being chronically underfunded, just as public health has. But is there a certain percentage the U.S. should be spending on primary care to make it high quality, or are there ways to up the level of expenditures going toward primary care? And then also, would the HHS office, would that require congressional action to establish?
Chris, you want to take
That's a
the first
great question. Go ahead, Bob. Bob knows at the tip of his fingertips what other countries pay for primary care.
Well, I was actually going to invite Chris, having been the instigator at the state level in this country, to talk first.
So we at the Milbank Memorial Fund have spent a fair amount of effort trying to understand what is the current spending rate in states and how much that varies. Bills on work done by the Primary Care Collaborative. The Commonwealth Fund has now joined on and produces it. I'll give you the policymaker answer. It depends. It depends on the population that you've got. So the primary care spend rate in Medicare is considerably lower than what it is in commercial. We have several studies that show that. That's to be expected, because the Medicare population is older and uses more healthcare services in general. So Medicare hovers around 4%. Commercial is closer to 6 or 7%. When we don't know Medicaid, because the quality of Medicaid information is not good. Hold on, we're going to get that in the next year or so. What should it be? We have actually, one of the reports, the special reports that Linda referred to, tried to start to compare the OECD numbers to the US numbers. It should be higher than our 5 to 7%, depending on the population. It is hard to make direct comparisons. I will say in Rhode Island, where I previously worked, and in Oregon, using different definitions for the commercial population, they have targeted numbers over 10% to build the kind of broad capacity. This is for the commercial population, to build the kind of broad team-based capacity that's required in the committee's definition of high-performing quality care. It's also important to note the reason why we're doing this spend. We're not doing this to save money in the short term. We're doing this to build capacity for high-quality primary care that the committee calls for, because that in and of itself is a common good. Too often primary care has boxed itself into corners saying, give us the money and we'll save you money in the next 2 years. The evidence doesn't support that. We think that's an unreasonable ask. We think that the ability to produce health, longer lifespans, and improved health equity is a good in and of itself.
Thank you, Chris. And Stephanie, to the second part of your question, I would just say that our consultations with former HHS leaders suggest that the authorization is there. That we don't have to wait for a congressional authorization to form a secretarial council or the advisory committee to it.
Thank you all. It looks like those are all the questions we have time for today. And if we didn't get to you, I sincerely apologize. We had over 500 attendees at one point, so we're not all too zoomed out. And once you exit this webinar, you'll be redirected to our report page. Again, that's nationalacademies.org/primary care. And also just a plug, in June, we'll have a series of 5 weekly public webinars, and they'll be focusing on the 5 objectives from the report. So that's payment, access and equity, training and workforce, digital health, and accountability and implementation. Again, if you go to that study page, you'll get all the updates and registration information for those. Once again, I'd like to thank our committee members for their hard work. I'd like to thank Dr. Zhao for joining us today. And thank you all again for participating. Have a wonderful rest of your afternoon.
Thank you.